As I mentioned, I'm joined here by, Dr. Peter Salama, who is in charge of UNICEF's global response to the Ebola outbreak. He's just returned to the country, to the U.S. from the three countries. Doctor, welcome.
Thank you very much. Good morning, colleagues. It's been more than 6 months since the first cases of Ebola were confirmed, and 3 months since WHO announced that the outbreak was a public health emergency of international concern. So it's an opportune moment to ask, where are we in the epidemic, and what have we learned? Clearly, this is an unprecedented outbreak in terms of both scale and complexity. It's of existential significance for the three most affected countries, and as an international global health community, we are in uncharted waters. While cumulatively, the numbers continue to go up and will approach 14,000 this week, there are also signs of hope. Nigeria and Senegal have put out their outbreaks. The rate of new infections in Liberia appears to be stabilizing, if not declining. However, because the three countries represent one outbreak zone or epidemiological block in public health terms, we'll not be able to rest anywhere in the world until the last embers of the outbreak are extinguished at their source, simultaneously in all three countries. So what have we learned? I think there are two main lessons so far. First, that this is a twin epidemic. It's an epidemic of a virus, but also an epidemic of global fear and ignorance. And with fear and ignorance, sadly, comes stigma and discrimination. We must tackle both epidemics to be successful. The fear, of course, manifests itself in travel bans and various restrictions all around the world, and is also present at the local level. A couple of weeks ago, UNICEF and its partners supported the first conference of Ebola survivors in Sierra Leone with around 40 participants. All survivors reported facing serious shame and discrimination, and none were currently employed, even those who had previously worked as nurses. Visiting Port Loko, a 2-hour drive from Freetown recently, I was struck by something I'd never seen before. Visible fear in the eyes of health workers, who of course we usually rely on for calm reassurance in times of crisis. I guess it's not surprising considering so many of their colleagues have died in the outbreak so far. The second major lesson is that communities represent the front lines in this battle. As important as the focus on treatment units and the number of beds and foreign medical teams has been, and indeed still more are needed, we cannot treat our way out of this outbreak. We must stop the flow of new cases, and we must do so not just in capital cities and towns, but in remote rural areas. And I believe the only way we can do so is for communities themselves to stand up and say, enough is enough. Unsafe burial practices and not taking sick relatives to be isolated and cared for early in their illness are the two main drivers of the outbreak. Communities in Lofa County in Liberia, and more recently in Monrovia, are finding solutions to these problems. We must help them continue to do so by working with and reinforcing the work of religious and community leaders and ensuring that facilities for isolation and care are safe and are available closer to where people live and to where they may die. And finally, a word on children. Children account for around 1/5 of all confirmed cases of Ebola to date. But perhaps even more important than the direct impact on children is the indirect one. Of course, the Ebola epidemic has been terrifying for everyone. But picture for a moment the world from the perspective of the millions of children in the three most affected countries. Death is all around them. They see medical personnel in masks and protective equipment taking away dead bodies and spraying mysterious liquids. Schools are closed, and primary healthcare services have become unreliable. In Liberia alone, the coverage of basic services such as immunization may have dropped by more than 50% this year. They are discouraged from playing with other children and confined to their homes. Life as they knew it has simply been turned upside down. Specifically, more than an estimated 4,000 children have been made orphans by the outbreak. Many more have been sent away for their own protection or because they've been rejected by their extended families. Many more child survivors languish alone in quarantine centres, not knowing whether their parents are alive or dead. I don't think we can, in any way, shape or form, overestimate the psychosocial impact of the crisis on children in these affected countries. So we must defeat Ebola before it defeats everything else we've been doing for children in these countries. Communities are showing us the way. We must support them more, at scale and at speed. I thank you.
Thank you very much. To Evelyn?
Thank you very much, Dr. Salama. I welcome you on behalf of the United Nations Correspondents Association. My name is Evelyn Leopold. I wonder, will there be if and when Ebola subsides, will there be a health system in these three countries? Or can you get an aspirin if you don't have Ebola?
It's a great question. And I think, as I was alluding to in the response, we've certainly seen a huge impact of the Ebola crisis on the primary healthcare systems, in fact, in all three countries. And some of the data suggests a decline in immunization coverage by up to 2/3 in countries such as Liberia, compared to data from last year. So it's certainly having an impact. We know it's also having an impact on the rate of skilled providers being able to deliver babies across the country as well. So a dramatic decline in basic health services. And I think as well, it's important to point out that it's no coincidence, in a sense, that the Ebola outbreak has concentrated on these countries with very fragile primary healthcare systems. So part of our challenge is, as we respond to the Ebola crisis, to do so in such a way that it's building on these community programs and actually supporting them, because they will in the end be the best way of revitalizing primary health care. So for example, one of the programs for Ebola that we're supporting at UNICEF is community care centers. And these community care centers are basically small care and treatment units that help families isolate their sick relatives, but also care for them at a decentralized level, way out in rural and marginalized communities. Of course, as we're supporting these community care centers, we're using community health workers and people from the community to actually work in the programs. So these will provide the basis for helping us build back better in terms of revitalizing the primary healthcare system after the crisis is over.
Thank you. Matthew?
Hi, my name is Matthew Carpenter. I'm a reporter for Yomiuri Shimbun, a Japanese newspaper. My question is, you talked about stigma among survivors and healthcare workers. Have you seen a decline in enthusiasm in numbers of people willing to volunteer to help combat Ebola since the spread of fear and paranoia in recent weeks?
So, of course, the fear has been there from the outset, from day one. And remember that we've never, ever faced, as a global health community, an Ebola outbreak of this scale and complexity. So we don't have anything to compare to, Matthew, in terms of the historic trends. What we do know and can say, though, is that it is difficult to attract the most highly qualified, the best people to work in these countries. As committed as our staff are at UNICEF or the other UN colleagues and civil society colleagues around the world that are responding in large numbers, we know that even if they're willing to go, very often their families can convince them that it's not a great idea. At UNICEF, we're in the process of doubling our staffing from a pre-crisis capacity of around 300 to around 600 over the course of the next couple of weeks. And we are looking at really increasing by hundreds, if not thousands, the staff we bring to bear on this outbreak in the coming months.
Thank you. Matthew?
Sure. Thanks a lot. Matthew Lee, Intercity Press, on behalf of the Free UN Coalition for Access. Thanks a lot for this briefing. Actually, I'll ask in reverse order. Now that you've mentioned staffing, could you say for that number, how many of those are international staff you would bring in, how many are national staff that you'd hire in the country, and also whether their rights to medical evacuation and treatment, particularly evacuation outside of the country, would be the same? And I wanted, last time, I think it was Sarah Crow was here, and she spoke to us about a school where people were essentially quarantined behind barbed wire in a school because they were thought to have Ebola. And I wanted to know, first of all, what's UNICEF's thinking about Are there kind of informal, community enforced quarantines? And also, what's the impact on the school, on schooling and the use of schools for that? But how do you feel about the use of schools to quarantine people that are showing those symptoms? Thanks.
So on your first question, roughly a third of all of our staff working in these three countries are international staff members. So it's a ratio of about 1/3 to 2/3. In terms of the access to services, as Stefan was referring to earlier, in terms of medical care for people that become positive. This is the number one priority for the SG's office, for Anthony Banbury, for our head of agency, Tony Lake, and indeed the entire global health community, to ensure that not only health workers, and I think this is an important distinction, but all people responding to the Ebola crisis, for the UN, for international NGOs, even for local governments, are able to access the minimum quality care if indeed they do become positive. And that's really our position on that. Now, the issue of whether to evacuate or not to medically evacuate there are several parameters one has to look at in making that decision. First of all, the medical and clinical assessment of is it the right thing to do from a clinical perspective, and it isn't always. Often it is. There also has to be transport available, and there also has to be a receiving country government willing to accept the person. And so all of those factors need to be included in that decision, which is really made primarily by our colleagues at the UN Medical Service and WHO. In terms of schools, it's an important question. At the moment, schools have either been cancelled or suspended in all three countries, affecting up to 5 million school-going children in the three countries. So it's a major issue. I mean, as I said, life for children has changed dramatically in all of those three countries, and so has their sense of normality, which of course school brings. On the question of whether we should use schools for quarantine or not, I think the most important thing to say is what communities need, and this is really a linchpin of the UNICEF approach, is alternative options to isolate and care for their sick relatives close to home. At the moment, we are putting communities in a very difficult position. We're saying either you keep your relatives at home and run all of the risks associated with caring for them, or by and large, you make a very difficult decision to send them hundreds of miles away to distant urban centers or towns where they may never hear the outcome of what happened to their loved one. And I think what we need to do now is really decentralize services. And we're not talking about lesser standards of care. We're talking about decentralized care right out to the communities. And that's really the linchpin of UNICEF's approach in supporting community care centers under the overall UN umbrella of UNMIR.
Maggie?
Margaret Bashir from Voice of America. Dr. Salama, is UNICEF still able to continue its other programs in light of the Ebola response? Are you doing immunizations and things like that, or is everything shifted now to the urgency of the Ebola response? And when you say 600 workers, it's all Ebola, or is it some for the other programs? If you could just expand on that.
I think I said earlier, Margaret, if we don't stop the outbreak, if we don't defeat Ebola, it's going to defeat everything that we've been doing in support of children collectively in these countries for many years. And we're already seeing that detrimental impact on education services, on primary healthcare services. So for us, the number one priority for the next few months has to be to put all of our efforts, all of our staffing, all of our resources behind stopping the outbreak. At the same time, we can and should do so in such a way that it has a collateral benefit to the rest of the programs. So as we're going in, for example, to set up community care centers, we can do so in such a way that we do revitalize primary healthcare services. So we are, for example, supporting immunization work and revitalization in all three countries through support to vaccines, through support to training of health workers and support to logistics for using those same community health workers and networks to respond to Ebola, but also to do more than that. And when you look even at some of our protocols, whether it's the MSF type of protocols in Ebola treatment units, or whether it's the more community-based protocols in community care centers, the first thing that those protocols say is that because we don't know immediately when a patient shows up with a fever, for example, whether that is Ebola or whether it's something else, they have to be treated as if they would have malaria, as if they had malaria. They also have to be treated with broad-spectrum antibiotics to cover all of the other potential causes of the fever until a confirmatory diagnosis is made. So through all of those programs, we hope to be able to support a range of causes of ill health that go beyond Ebola. But I would reiterate, the primary objective for the next few months has to be to stop the Ebola outbreak, because if we don't do that, we really will see the economies and indeed the whole social services of these countries continue to collapse.
Anna,
Thank you, Stefan. I wanted to ask why Liberia, Sierra Leone, and Guinea? What were these countries missing or lacking that they became such an easy target for this dangerous virus? And also, it's a known fact that when we're dealing with a virus or possible epidemic or pandemic, the most important part is the first response, first steps. So now that you know the situation from inside out and you've been there and you've seen these countries and what's being done, what do you think should or could have been done differently to minimize the losses, and what kind of prognosis you can have for these countries? And also I would really appreciate if you could tell some slight differences or peculiarities of these three countries, how the situation is different in each of them and what kind of prognosis it can have for them. Thank you.
So on your question of what have we learned? I think I covered a little bit of that in the more formal remarks. I mean, one of the critical facets we've learned is that we certainly need to set up Ebola treatment units with the right capacity nationally, but it's not just about the number of beds, it's about the distribution of those beds. They have to be dispersed throughout the country in areas where transmission is occurring, and that increasingly will include and does include the most rural and marginalized populations in all three countries. And when we look at some of the lessons learned from Nigeria and Senegal that responded very well and were able to stamp out their outbreaks quite quickly, as you alluded to, they responded very quickly and very dramatically, very rigorous response quickly. And I think we've learned that both for those countries, but even for new outbreaks that occur in spotty ways in the three most affected countries, we have to stamp them out quickly before they become chains of transmission that affect hundreds, if not thousands, of people in a new way in even the existing three countries. I think we've also learned from the Democratic Republic of Congo, which has a different strain of Ebola at the moment, but still an interesting comparison, because there's a country which one would think, gosh, a country that's been through civil war, how have they managed to contain their outbreak? And again, very similar lessons learned. Trained, integrated teams of people deployed quickly, rapid response to the most rural parts of the country, and quickly engaging communities to change their behaviors and isolate and treat the cases within a matter of hours, if not days. And so that's really the critical lesson from those countries that have done well. So we've learned something, certainly, for the three affected countries. Why these three countries? As I alluded to earlier, particularly in the cases of Liberia and Sierra Leone, countries that had dramatic, extended civil wars that really devastated their ability to set up high-quality primary healthcare systems across the country. They had really poor doctor-to-nurse-to-patient ratios in those countries. They had very rudimentary services outside the capitals and major towns. And although some of them, like Liberia, had been making progress in recent years, the progress was not enough. And Sierra Leone, for example, had the second highest under-5 mortality rate of anywhere in the world prior to the outbreak. So again, in that sense, not a huge surprise that these countries with very rudimentary health systems suffered from the outbreak the most. In terms of the differences between the three countries, Liberia has had the most extensive, highest transmission outbreak, and perhaps for that reason, may be starting to see the beginnings of at least a decline in the rate of new infections. Now, I say we can be optimistically cautious in relation to Liberia, but certainly even in Liberia, the story is not over. We are seeing communities responding. We are seeing a much more robust international response, and I think we have signs of hope in Liberia. In the other two countries, transmission is still increasing in terms of the rate of new infections, and we still have to redouble our efforts across all 3 countries, because what I mentioned earlier is very important. We have to treat these countries almost as one block, one epidemiological zone. So even if one country does well, there's a potential for the countries not doing well to reseed the outbreak in the other countries, and indeed all over the world, as we've seen most dramatically in Europe and North America in recent weeks.
Yeah. I think you have answered about many questions, but here, are you considering isolating those areas which have been intact or not infected by disease, so that the spread of the epidemic doesn't go to these areas? Has there been any measures like that?
Yeah, it's an excellent question. So in Liberia and Sierra Leone, the disease is very widespread. It's affecting almost entire districts of the 2 countries. In Guinea, it's a little more localized at this stage of the crisis, and so we can hope to really respond quickly to new outbreaks and to really prevent outbreaks in areas that haven't yet suffered transmission. But I think your question goes beyond the 3 countries, and it's an important point, which is that we have the opportunity now to prevent outbreaks in what we call the high-risk countries for potential outbreaks in West Africa and in other parts of the continent. And working closely with our colleagues at WHO, we are putting in place emergency preparedness plans in those countries. So first of all, with the objective, of course, of preventing any cases, but should they have a case, particularly imported cases, as is entirely possible, as we've seen in the recent outbreak in Mali, then they'll be able to respond very quickly and very robustly before those chains of transmission are really well entrenched in those countries.
In the back, and then Joe.
Thank you. You talked about the children who became orphaned because of Ebola. I understand that the number 1 priority is to address the actual outbreak, but are there any initiatives taken by UNICEF to help specifically those children? And you also talked about the drop in the number of vaccinations. Have you seen an effect already of other diseases spreading more? And do you anticipate that that's going to become a major issue later on? Thank you.
Certainly, I consider the work that we're doing in support of children who are orphaned or separated or unaccompanied or indeed stigmatized because of the outbreak as really a central part of our initial response to the outbreak, because for us, especially at UNICEF, but all of the organizations focused on children, it goes to values, it goes to mission, and it goes to a core part of the community caring side of the response. So that for us is very much on the front burner of our response. So we are working particularly with local civil society organizations to look at family reunification and tracing, and that work has already begun in all 3 countries, to look at alternative care for children who either don't have relatives, they're orphaned, don't have an extended family, or indeed whose extended families or relatives reject them. One of the interesting elements of this story is really now the identification of survivors of the outbreak, because they're also, on one hand, a stigmatized group, but they're also a group that's ready and willing to support our response, including our response in terms of caring for children that are orphaned or made vulnerable by the Ebola outbreak. And I think that's a very important aspect of the response that now we're working in all 3 countries with in terms of the survivors. In terms of the other disease outbreaks, there is very preliminary information, and I stress it is of a very preliminary nature, because as you can imagine, in these 3 countries, not only are the health systems suffering, but also, of course, all of the routine data collection systems are also suffering or are indeed down. But we do have anecdotal information to suggest that cases of vaccine-preventable diseases may be increasing, and indeed that malaria, for example, may be becoming an increasing problem. But I stress that that's preliminary information. But of course, it's logical to believe that as our immunization coverage rates decline, that of course our cases of vaccine-preventable diseases will go up.
Joe?
Yeah, Joseph Klein, Canada Free Press. Just building first on that point about other diseases. Flu season's coming upon us. Flu causes many more deaths potentially because it's far more contagious than Ebola. Polio outbreaks have been occurring outside those 3 countries and in other parts of the area. So again, to what extent is your work impacted adversely by the focus on Ebola in light of the fact that these other diseases could cause more deaths? And secondly, you alluded to fear. And I guess a question I have is, to what degree of scientific certainty is there that Ebola, for example, cannot be spread through droplets, which people, within a certain period of time can touch and then spread that way? Because the CDC in the United States has added that element to a means of transmission, and that this is a factor that could cause fear among some people. So I'd like you to comment on that.
Okay, first point on the numbers. The numbers that are the official WHO data at the moment suggest more than 13,500 confirmed cases of Ebola. But let's remember that that figure is likely to represent a major underestimate, because we know that many people have died with Ebola and those cases have not been counted. So this, in all likelihood, represents a gross underestimate. But I think the more important way to see the Ebola crisis is the fact that we have a time-limited window of opportunity to stop it. If we don't stop it, it will continue to cause economic collapse, certainly decline, but likely collapse in these three countries particularly. And of course, without any budget to support social services in these countries, an entire collapse of the social services in those three countries, which means that it'll have an impact not just on our ability to respond to Ebola, but on our ability to do anything else in these three countries, in terms of healthcare, in terms of education, in terms of social protection for the most vulnerable. So I don't believe I exaggerate when I say that this is of existential significance to the three countries concerned. Now, when you start to put that in a global perspective, I think the discussion is certainly complex. On one hand, again, there are diseases that cause more death in terms of numbers globally, of course, than Ebola today. But when you look at the amount of panic and fear and international disruption that this outbreak has already caused globally, it does have an indirect impact that goes way beyond just the simple case count today, and will continue to unless we stop the outbreak at its source. So again, I think the message here is, let's make a concerted effort during this time-limited window of opportunity to stop this outbreak in its tracks, and we can all go back to doing the other important work on global health and development that we need to do all around the world, including, as you mentioned, responding to global polio outbreaks, responding to the potential flu outbreaks, and all of the other important work on under 5 and maternal mortality that organizations like UNICEF are focused on. In terms of the second part of your question, sorry, just remind me.
Yes, you had alluded to one of the lessons learned about fear, but possibly I think you characterize as irrational fear to some extent. But the CDC in the United States, and I think other agencies, have indicated that there may be other ways to transmit Ebola than was originally thought, for example, through droplets that could be touched by people and so forth, not necessarily just the exchange of bodily fluids. So this uncertainty contributes to fear, and so I'd like your comment on that, and whether that's a valid concern for some countries that may wish to impose limited travel bans, for example.
Yeah. I think the most important thing to state in terms of the medical facts about Ebola are that what we do know is that you cannot transmit the disease if you're not symptomatic. And the symptoms of Ebola are very clear and very well documented, led by the critical sign and symptom of fever, diarrhea, vomiting, headache, joint pains, and unexplained bleeding. So if you're not symptomatic, you cannot transmit the disease. And I think that's the most important medical fact that we need to keep on reiterating, that's relevant to all of the discussions that we've heard globally, both in the three most affected countries, but also in terms of the global discussions around when and how to conduct monitoring of individuals who've traveled to affected areas or who are direct contacts of patients, which are, of course, the people in the higher risk categories.
Great. Doctor, thank you very much.